Good evening, everyone, and welcome to our live talk about spinal cord stimulation. We're going to get started in just a moment, but before we begin, I'm going to take a second to explain tonight's format. With us this evening, we have Dr. Bernard Abrams. To keep background noise down, we have everyone muted, and if you find your device becomes unmuted during the talk, please return it to mute status. We encourage questions and ask that you submit them through the Zoom chat feature, which you'll find in your Zoom toolbar. Feel free to submit your questions and we'll answer them during the Q&A section of the presentation. I've received a number of questions ahead of time and we'll ask them at the beginning of the Q&A portion to get us started. Now, a brief introduction of Ortho South. We offer comprehensive orthopedic care across 7 locations in the Mid-South region. We have surgery centers in Germantown, Tennessee and South Haven, Mississippi, excuse me. And we are proud to announce that our Germantown Surgery Center was recently ranked in Newsweek top ASC in America. We offer Saturday clinic hours in Bartlett, evening hours in East Memphis, and a 24/7 urgent care triage line for those after hours injuries. Now to introduce our speaker. Dr. Abrams is a fellowship-trained interventional spine specialist practicing at the Ortho South Germantown, Memphis Briarcrest, and South Haven clinics. Dr. Abrams completed his surgical internship at the Joint Civilian Military Program at Miami Valley Hospital in the Wright State University Boonshoff School of Medicine Department of Surgery in Dayton, Ohio. He then transitioned to gain further leadership and clinical skills as a combat search and rescue medical director and flight surgeon in the United States Air Force at Nellis Air Force Base. Following those years, Dr. Abrams then completed a residency in physical medicine and rehabilitation at Johns Hopkins Hospital in Baltimore, Maryland, followed by a fellowship in pain medicine at Milton S. Hershey Medical Center, Penn State Health, Hershey, Pennsylvania. He is a graduate of UT Health Science Center in Memphis and received his bachelor's in chemistry from the University of Pittsburgh. In his free time, Dr. Abrams enjoys riding his motorcycle, playing basketball, and competitive shooting. So without further ado, take it away, Dr. Abrams.
I apologize, everyone. I think I was muted. So as Savannah kindly introduced me, I'm Dr. Abrams, and I hope everyone can hear me fine this evening. And thank you for joining in. I look forward to giving you some information about spinal cord stimulation. As she mentioned, I am one of the newest staff at Ortho South, and I have a strong interest in neuromodulation, and today we'll be talking about spinal cord stimulation. This is a good option for patients who have radicular, which is nerve pain, often called a pinched nerve, and also nerve pain that involves specifically the back. Next slide. So our objective from this evening's talk will be able to, at the end, you should have a good understanding of the indications for spinal cord stimulation, specifically what we call dorsal column stimulation. You should have a good understanding of the outcomes, who are good candidates for spinal cord stimulation, how it may benefit you as a patient, what are the alternatives, and what are the risks involved. And in addition, I hope you have a good understanding of the process of getting a spinal cord stimulator placed, which sometimes can be quite lengthy, particularly during this COVID pandemic, as the rate limiting step is being able to see a psychologist or psychotherapist. And then also it can help you determine your personal goals of getting a spinal cord stimulator placed. Next slide. I have no conflicts of interest to report. I did want to give some thanks to Kevin Reed, who works for Nevro, which is a spinal cord stimulation company, for some assistance with some background information. Next slide. So we went over that briefly. Next slide. So what is spinal cord stimulation? This is basically the use of a vibration type signal, which stimulates the nerve fibers in the back of the spinal cord, particularly in the epidural space. And it competes against nerve fiber signals that are sending pain from an area that's injured in the body to the brain. The frequency may be stimulated and you may feel it, which is called paresthesias or tonic stimulation. And there's also ways that you don't feel it, which we call subthreshold. And there's also newer algorithms, which are combinations of paresthesia and subthreshold to enhance pain relief. All this is done by a electrode, which we call a lead, which is basically a wire that's placed into the epidural space. If you have had an epidural in the past, you may be familiar with that procedure, and this is done very similar. And this is not a nerve block. So next slide. So moving on, the components that comprise the spinal cord stimulation are two main components: the electrode, which you may hear called a lead, and then the pulse generator, which acts as a battery and also sends the algorithm, which is the mix of the way the nerves are stimulated as far as how fast, how strong, and how frequent to block the pain signals. On the left, you'll see two types of leads. The wide flat one is called a paddle lead. This is typically placed by a neurosurgeon or a spine surgeon. And then the one on the right is called a percutaneous lead, which is the standard lead, which can be placed by a spine specialist or interventionist like myself, or a spine or neurosurgeon as well. On the right, you can see different type of batteries that come from 4 major companies that provide spinal cord stimulation devices. These batteries can last anywhere from 4 to 10 years, and that depends if you have a rechargeable battery, a non-rechargeable battery, or how frequent that you use it. There also are batteryless systems, which work by radio frequency, where there is a signal sent just like you would in a touch credit card to the device underneath the skin, which activates it when you wear the particular device. Next slide. So moving on, how does it work? On the left-hand side, you see a schematic that shows the combination, as I mentioned earlier. The battery is typically placed somewhere in the lower back above the buttock or in the lower part of the back underneath the skin about 1 centimeter so it can communicate with your device. The devices look different. Some look like a cell phone. Some look like a household remote with a screen. And this allows you to fine tune your personal spinal cord stimulator to turn it on and off. And also you can personally adjust the strength and signal intensity based to your liking. On the right-hand side, you'll see an X-ray of a patient. In the middle of the screen, you see the alternating pattern of electrodes. This is what actually sends the stimulation to the spinal cord. You can follow that down to the wire, and in an X-ray, everything is the opposite side. So that battery is in the patient's right lower back, and you can see the system being powered. You can place 1 lead, but traditionally now people place 2 leads because it's very common that as people age, they may have pain on the opposite side. You also get better capture, which means better pain relief with 2 leads, and you always have a backup. And so that's usually the standard approach most days, unless you get extremely excellent coverage with 1 lead. Next slide. What are the indications for a spinal cord stimulator? This device is found to be most helpful in a lot of conditions, but the most helpful ones are retractable radicular pain. This is pain along a nerve root, such as from a pinched nerve, bulged or herniated disc. This is the most common reason. Plexopathy is an injury to a confluence of the nerves as they leave the upper or lower spine, and they merge to something called the plexus. Neuropathic axial back pain. This will be people who have back pain from lumbar stenosis, or they have nerve type pain only in the back. CRPS, which is complex regional pain syndrome, the second most common reason, which is a condition involving severe pain sensitivity, pain with normal stimulation, which typically affects the lower body or the upper body, such as the hands or feet. And then also any kind of pain for neuropathy. This could be from diabetes, an unknown cause, or something such as Sjogren's or other autoimmune conditions that affect the nerves involving the hands or the feet. It may also help people, but not as good, with post-spinal surgery syndrome. This is also called post-laminectomy or failed back syndrome. Phantom limb pain, which someone may experience after an amputation. Intercostal neuralgia or post-herpetic neuralgia, which people may get from rib fractures or shingles. And then also thoracotomy pain for anyone who's maybe had open heart surgery or lung surgery for cancer, and they have pain along the ribs. Next slide. Unfortunately, spinal cord stimulation is not best for everyone. People who typically have poor outcomes, meaning they don't get pain relief from the trial, which we'll talk about, or the permanent implantation, are people who are undergoing active litigation, which means you're involved in a lawsuit for personal injury or workplace injury. People who have uncontrolled depression or anxiety. This does not mean you cannot be diagnosed with anxiety or depression and get a stimulator. It just means that it must be well managed. A history of any type of substance abuse. Cancer pain doesn't do well with this device. Smokers is what we call a relative contraindication, meaning it can be performed, but a lot of caution is recommended as active smokers have high rates of infection. Widespread pain syndromes. This would be something such as fibromyalgia. Bilateral pain. So pain involving the both arms and hands, or both thighs, legs, and feet, can get relief, but typically not as well when only one arm and hand or one leg, thigh, and foot are involved. Axial back pain, which means pain in the middle of the back that does not go outside of the trunk, also shows some evidence for benefit, but not as well. We see about 40 to 65% of people get greater than 50% of pain relief, whereas people who have radicular pain in the arms or in the legs and thighs may reach upwards towards 80% success rate with the trial. They get more than 50% pain relief. People who have failed the trial should not move on to a permanent implant. People who have severe cognitive deficits, this is not recommended, as they may have difficulty operating the device and may not get the full benefit. And then lastly, implanted cardiac devices, such as a pacemaker or defibrillator. This all depends on the company for which that device, for the cardiac reason, has been implanted. Most commonly, it's Medtronic, and we always recommend consulting with that company first to see if there's any negative interaction. Next slide. There are risk, benefits, and alternatives, some of which I mentioned. The most common risk with this procedure is infection, dural puncture, which can lead to a headache of the spinal fluid leaking out during the placement. Bleeding, we try to make sure no one's on a blood thinner, and people who need certain type of blood thinners for different conditions may be restricted because of the risk of an event such as a stroke or heart attack or serious blood clot can be increased during the time that you need to be off of the medication to do the trial and the implant. As I said earlier, failing the stimulator trial, there is the risk of device malfunction, a fracture of the wires, and also they may need to be taken out, explanted, and that could be due to an infection or a failure for the device to still work well. The alternatives are physical therapy, which most people have been through, managing the pain with medications, remedial surgery, which is having surgery again for a previous condition such as reconstructive surgery, and then primary surgery, which is having surgery for the condition which we want to do the stimulator. And then the benefits are many, which most people like, which is improved pain relief, reduction in your pain meds, improve ADLs, which are activities of daily living, such as doing normal community activities that you enjoy, brushing your teeth, combing your hair, getting in and out of bed, driving. Improve QOL, which stands for quality of life. That means enjoying your life more without focusing on pain. Improve function. That's general activities that you require necessary to live your daily life, or things you want to do that you have not been able to do. People return back to work sooner. And then people also have improved quality of sleep. Next slide. What are the outcomes? So spinal cord stimulation is not a new technique. It's actually been around since the 1960s, almost 60 years now. And it has been approved in the US by the FDA since the late 1980s, about 1984 to 86. Success is much greater, is deemed the greatest in people who have greater than 50% improvement in their pain during the trial. It can be used for many different spine conditions, and the literature shows, based on the combined information from different conditions, that people report an improvement of pain greater than 50% in about 50 to 80% of people who have a successful trial. It reduces the healthcare cost that was normally spent on medications, therapies, and doctor visits. It also reduces pain medication use. A lot of evidence shows 2 years after the implant, people report a 40 to 80% reduction in their pain medications. And 60% of people, it improves their activities of daily living, and 25% of people are able to go back to work full time. Unfortunately, the downside is the longer you have had chronic pain, the less likely spinal cord stimulators to help. Chronic pain is deemed pain that's been going on greater than 3 to 6 months. So sooner people fail to benefit from therapy, medications, and epidurals, and they do not desire surgery, the sooner you can get this trial done as an option to relieve your pain, the better your long-term outcomes are. Next slide. So what is the process of getting a spinal cord stimulator placed? It can be a lengthy process. And as I mentioned earlier, the rate limiting step is seeing the psychologist. It first begins by talking to your primary care for a referral, or if you're already established with a pain medicine or interventional spine provider, they can work with you. Ideally, you would have failed medications, physical therapies, and at least tried 2 epidurals that have failed to relieve your pain for greater than 3 months. Next, you get connected with a company. We usually like you to read about the different companies that are available, and they'll provide some resources at the end. These include Boston Scientific, Nevro, Medtronic, Abbott, St. Jude, and StemWave. These companies provide different types of systems, which are rechargeable, which last the longest. Non-rechargeable, you don't have to worry about recharging. These are good for elderly people or people who just don't desire recharging them on a frequent basis. And then radio frequency options are the ones that don't require a battery implanted underneath the skin. You simply wear a belt or fix a patch over the area of your stimulator. And when that's in place, it will charge your stimulator and you get pain relief. And when you don't want to use it, you simply take that off. Once you've researched this and decide this is something that you want to do, we then connect you with a rep and move towards the multi-step process. Next slide. The process begins with a referral to a psychotherapist or a psychologist. This is, as I mentioned earlier, to make sure you don't have uncontrolled depression or anxiety and that your home and social situation is stable. When you don't have these, people tend to have a poor outcome and never benefit from the stimulator. If the psychotherapist, psychologist clears you, meaning you understand why you get a device and everything is stable, then we typically get an MRI of your thoracic spine. So that's below your neck and above the lower rib to make sure there's enough space to place the electrode, which is entered through the lower back, and the lead is driven up towards the middle part of the back between the shoulder blades. If it is placed in the neck, it goes up into the middle portion of the neck. This is also important because some people have tightness in there, and we would not want to put that because it can compress the spinal cord and lead to a bad outcome, such as paralysis. Next, as I mentioned earlier, you'll be connected with a representative for the company you choose. They will work with the physician, such as myself, and you to get the trial approved by networking with your insurance and answering any questions you have along the process. Next slide. Once your insurance company has given the approval based on the documentation and you are allowed to move forward, and you have been cleared from the psychotherapy eval and the thoracic MRI, again, this is to show safety and clearance, we'll schedule for a spinal cord stimulator trial. The trial is where you wear the device for a period of anywhere from 3 to 8 days. And we ask that you do all normal activity that you would normally do that causes pain, or activities that you can't do that you want to do because it causes pain. During that time, you're restricted from showering, bathing, swimming, jacuzzis, anything involving water submersion. And we strongly recommend you do not do any bed rest. Typically, these trials are performed in an outpatient surgery center, but can be performed in an office based on a provider. And again, as I mentioned earlier, it's performed very similar to doing an epidural injection, whereby you lay on your belly, we clean your back sterilely, numb the skin, and place a device called a cannula into the back that we thread the wire through to get into the epidural space. Under X-ray guidance, we move the wire up to the location, and then we either stimulate your area where you have pain to make sure we have good coverage. And some devices don't require that at all. You just place it, and then the company will work with you to stimulate and gain pain relief afterwards. Next slide. During the trial phase, you'll be in constant connection with the representative who will ask you how your pain is doing and may adjust your device with different frequencies, strengths, and duration of stimulation to see if we can optimize your pain. At the end of the trial, you'll come to the physician's office and they will remove the device in office. It's simply taking it out of the skin and then putting a Band-Aid over that area. If you were happy with your pain relief and pain relief was at least 50%, then you will be deemed success and you can elect to have a permanent one placed. This may be performed by the same physician, such as myself, or sometimes this physician may refer you out to a partnering spine surgeon for permanent placement. There are different factors that contribute that, such as desired type of lead, where it will be placed, person's body type, and medical issues that may make it safe or not safe to do this in an outpatient setting versus maybe doing it in the same day setting at a hospital. Next slide. Resources you may find helpful on the companies that I typically will use here are listed. Medtronic is a very good company. They offer rechargeable and non-rechargeable systems. The most recent one is called DTM, and they use a particular battery called Intellis, which is rechargeable. This is a high frequency by their standard system, but it's actually kind of a mix of a higher end frequency mixed with different algorithms that work together in a combination to give pain relief. Nevro has two websites, nevro.com and HF10. They're known for their high frequency system, which has been FDA approved. They're typically labeled as the only one that has true high frequency, which is greater than 10,000 hertz. And that's what's unique about them. They only offer a rechargeable system. Their system doesn't require paresthesia mapping, which is during the placement, you're aroused and they stimulate it during the procedure, and then we help you relax again. You're not totally put to sleep like with anesthesia, but you just place their system, and then they contact you later the day and they work with you to gain pain relief. And then at the bottom, stemwavefreedom.com. Stemwave is another company, but they do not have an implantable battery, which we call it Eternal Pulse Generator, IPG. Their system is called the Freedom, and that's the one that I mentioned, where you wear a device such as a patch or a belt that has the battery inserted into that, and it sends a signal through radio frequency to the electrode lead to power it and gives you pain relief only when wearing that device. You will find with these devices, we recommend people not stimulate them continuously every day. We try to do something called neural dosing, which is stimulating the least amount as possible to get pain relief. What that means is you may stimulate your nerves half a day and get 1 week of pain relief. And so over time, you'll play with the system to figure out the least amount of time you need to stimulate your nerves to get the maximum amount of pain relief. Some people do require daily stimulation, but the vast majority of people can stimulate at a frequency less than every day. There's a lot of reports where people stimulate, for instance, 1 week, and then they get several months. And so they only stimulate 1 week every 3 or 4 months, and they get adequate pain relief. This also prolongs your battery life as well. Next slide. So here's some common frequently asked questions that you may be thinking of yourself, and we'll still have an open question session. So will this procedure reduce your pain medication needs? As I mentioned earlier, possibly. The evidence does show that 40 to 80% of patients report reduced medication usage at about 2 years after their device has been placed. And a lot of patients are able to get off their narcotic use, which, as we know, in the opioid epidemic is a big concern. What if you already have a spinal cord system placed? Well, depending on the type of system you have, it can be utilized, but sometimes it may have to be removed. A lot of the newer systems require significant battery use, and that's why they're rechargeable. And it may be simply switching out your battery to salvage the previous system. These newer frequencies may also offer you better pain relief if you've had a system for a long time and you feel like that system is failing to work as it had been. Unfortunately, spinal cord stimulators are similar to narcotic drugs, where if you stimulate the nerves too long for too frequent of a period, you can develop tolerance, just like you can become tolerant to a medication that doesn't work as well. And so we find people who stimulate their nerves too often, after a period of about 6 to 9 years of having it, it does not work as well. And again, that's why we recommend the neural dosing, which is stimulating at least as much as possible to get the longest amount of pain relief. What other high frequency systems are available? As I mentioned earlier, Nevro is the only company that's FDA approved for, quote, high frequency, which is greater than 10,000 hertz. This frequency is also pretty good for axial back pain, which is the pain just in the back. But as I mentioned before, pain in the legs and arms typically has better relief than pain in the back alone. The other companies have a lower frequency, somewhere between 800 and 5,000 hertz. And so they cannot say they're high frequency by law, but they use combinations of different things called pulse, bandwidth, frequency, to achieve pain relief, which are better than the traditional systems. These systems can be stimulated where you don't feel anything, again, which is called subthreshold or subtonic, or some people like to feel the tingling or slight vibration, which we call tonic stimulation or paresthesias. Next slide. You may also ask, is this procedure covered by my insurance? In most cases, it is, and with good patient selection, most insurances, again, will cover it, particularly Medicare. But your insurance has something called local coverage determination, which has the final say. There may be different requirements based on your insurance before getting one of these placed, which may be that you have to have tried surgery and failed. Other companies, you do not have to have tried surgery and failed, but maybe have tried epidurals and different medications, as I mentioned previously. Excuse me. Will you feel anything? So during the procedure, we keep you calm. During the trial, I typically give sedation and local anesthetic. We don't want you completely out, such as a major surgery, because we may have to rouse you to stimulate, depending on the company. But we keep you a little drowsy so you're not aware of what's going on. Otherwise, it's performed, as I mentioned, similar to an epidural. For the permanent placement, you typically do get anesthesia, but it's not necessary if you chose not to. Some people have contraindications, which mean they have medical issues where they should not have anesthesia, and this can be done with local anesthetic as well. Is your system MRI compatible? A lot of people have to get MRIs for various reasons, neurological reasons where they may need their brain scanned or they have ongoing other issues in their body. Nevro has been deemed MRI compatible, and so has Medtronic's newer systems. The other systems are what we call MRI conditional, meaning depending on what part of your body is being MRI'd, you may or may not be able to get that done with that device and may have to do an alternative type of advanced imaging called a CT scan. Next slide. So just a little back joke. And at this time, I think we'll move and open for open questions. Next slide.
Yes, sir. Thank you, Dr. Abrams.
Okay.
We have 2 questions that have already been submitted, and the first is, which option do people tend to choose the most? Rechargeable, non-rechargeable, or radio frequency?
So the answer to that, it's a very personal choice. I'd say if I had to state, a lot of people probably now if they're doing high frequency, meaning if they have back and leg pain, I think most people I would recommend is doing a high frequency system, which would be rechargeable. You can certainly do it non-rechargeable if you don't want to do that, but your battery will likely die half the time that's expected to be serviced, which is every 9 to 10 years. And people who have high frequency systems with non-rechargeable batteries typically have the battery fail about 4 to 5 years afterwards. So you'll be looking at getting a battery exchange that often. I tend to find older people who don't want to worry about that or very busy, like the non-rechargeable, because they don't have to worry about getting up or charging it, or maybe they have pain and had forgotten to charge it, and now they have to wait to charge it. So you're aware charging, depending on the device, does not take long, typically about 30 to 45 minutes of your day for use. And again, depending on how long you stimulate, you may get several days of use from that one battery charge, or it may just be that single day's use. But the thing is, some people again stimulate for one day and they get many days or weeks of relief. And so you don't have to do it every day. I would say, some people are averse to having an implantable battery, although they're having the lead implanted in their spine. And it's something about just having that battery placed underneath the skin, and they'll typically go with the radio frequency options.
All right, and we have another request. Can you quickly recap the first step a patient should take if they're interested in being vetted as a candidate for this procedure?
So the first step you should do is get connected with a interventionalist, someone who does spinal cord stimulator trials for an evaluation. Typically, most places have a standard questionnaire or personal list of questions that they ask patients to make sure they're good candidates. These things look at your medical history. As I mentioned earlier, they want to make sure you don't have any substance abuse, you don't have uncontrolled depression or anxiety. They should review your chart to see have you tried epidurals, medications, and therapies that have failed. And then they'll examine you to see what type of pain you actually have. If you meet the criteria and they think you'd be a good candidate, the first step, as I mentioned earlier, would be referral to a psychologist or psychotherapist who has experience with spinal cord stimulator evaluations to make sure you'd be a good candidate. The majority of insurances do require the psychological evaluation.
Thank you, Dr. Abrams. And I think we have one more question. What percentage of trial participants will go on to permanent placement?
So that's somewhere between 60 and 85% of people who are appropriately selected for the trial. There are people that if you do a trial on that are definitely probably not going to benefit. And then there's some that's 50-50. It really depends on the condition. People who have what's called post-laminectomy syndrome, which is a very common reason for a trial. These are people who have had back surgery for whatever reason. Typically back surgery is to prevent permanent neurological compromise, but these patients also have pain. And so after they have back surgery, either they have the same pain that did not improve, or maybe sometimes they have pain related to the surgery and they don't know why. these people can have a benefit, and they're somewhere probably about 40 to 50% effective as far as having a successful trial. People who have the most success are people who have pain in one limb, meaning an arm, forearm, and hand, or thigh, leg, and foot, typically have the highest success rate. And again, that can be anywhere between 60 and 85% of people will have 50% or better pain relief, which is the minimum amount of pain relief to deem the trial successful.
All right, thank you, Dr. Abrams. If there is no more questions, I would say this concludes our webinar. Thank you so much for coming and listening to Dr. Abrams speak. And Dr. Abrams, thank you for taking the time to share this presentation with us.
You're welcome. And I hope everyone's got some information from this. I think this is kind of the future of pain management. There's a lot of different medications coming out in the future, but neuromodulation of the spinal cord or the peripheral nerves is probably going to be the wave of the future. And I think it's a way to limit pain medication use, which no one wants to take medications every day, and gain back some of your quality of life and function.
All right, thank you so much, everyone. Y'all have a good night.
All right, thank you as well. Everyone take care.